So
Yes,
welcome everyone.
thank you.
Uh,
I just hope my dog is not going to bark a lot, but
no
It's
worries.
okay.
It's okay.
Everything is okay.
All right. So on behalf of Mission Brain Foundation Chapter Universidad de Guanajuato, we are very happy to welcome you to our first Global Grand Rounds session with Dr. Angel Lee. He will talk to us about the management of intracranial aneurysms using state-of-the-art endovascular techniques. And yes, so my name is Gerardo Gomez. I'm president of the chapter at Universidad de Guanajuato, and I will moderate alongside Francisco Gomez. He's our general coordinator. He has done an amazing job putting this together, and without him, we wouldn't be here today. So big thanks to him. And the format will be very straightforward. We will give a very, very quick overview of what global grand rounds are, and we'll introduce our speaker. They will present, and we will close with a short Q&A session. So the idea of Global Grand Rounds started last year in Mexico City. We gathered the presidents of the chapters in Mexico, in Mexico City, and we were thinking about ideas on how to bring the chapters not only among Mexico but among the entire world. So Global Grand Rounds is an idea that came, and we're very happy to start with this. And the main goal is to share with students, residents, and faculty, and researchers how neuroscience is practiced worldwide. This includes research, includes neurology, neurosurgery, psychiatry, etc. And we'll have stellar speakers sharing their fields of expertise with us, and we will keep the legacy of the foundation with a treat, mainly educate and empower our students in chapters. Um, so we don't have everyone joining us yet, but we have people registered from Mexico, from Thailand, Dominican Republic, Peru, India, Colombia, Argentina, Libya, and Bolivia. So we hope to keep growing this audience, and we hope to create a space where everyone can feel free to learn and learn about how neuroscience is practiced around the world. Um, so yeah, if anyone is interested in participating, please contact us. We're starting a little bit local with Dr. Lee from Mexico City, but if anyone from Thailand or any other country wants to help us organize this, you would be very helpful to help us keep bringing amazing speakers to this great space. And yeah, just contact us in the email here. And yes, I'll allow Fran to introduce our guest speakers tonight.
So
So
thank you,
you're welcome.
Gerardo. It's for me an honor to present Dr. Angel Lee. He's a graduate from the University of Pierre at Marie Curie in Paris as a general practitioner, completing his specialty as a neurosurgeon at the University Claude Bernard in Lyon, and also pursuing his subspecialty in therapy neurological endovascular at the National Institute of Neurology and Neurosurgery in Mexico City. As well, I don't know if Dr. Christopher Mahler is now here, but I will present him as well. And well, Dr. Christopher Mahler is a graduate from the UNAM, the National University of Mexico, as a general practitioner, performing his specialty in neurosurgery at the General Hospital of Mexico, and then performing his subspecialty in the school base in Sao Paulo, Brazil, and another subspecialty in neurological endovascular therapy at the National Institute of Neurology and Neurosurgery at Mexico City. Well, I give the Dr. Lee, it's your turn to speak, so it's perfect now. Thank you.
yeah, thank you very much. I don't know if I can share my screen.
I
guess I can.
Yes, we can
yes,
see it now.
Exactly. So, well, thank you very much for your kind invitation. But I'm awfully sorry if you only have amazing speakers. I might go away now because I'm not quite sure I'm an amazing speaker. but I like what I do, and it's a long time I've been doing this. So not all my slides are in English. Some of them are Spanish, but of course I will translate them meanwhile. So, well, this is a general introduction, a general lecture, because of course I'm going to focus on what I propose, which is the endovascular treatment of intracranial aneurysms. But this lecture is a kind of introduction to what we do. It's a kind of a new discipline. What I mean for new? Well, it exists since the middle of the second half of the 20th century, and in fact, the first guy who started having the idea of treating vascular diseases by endovascular means was a Soviet neurosurgeon. So these what I'm going to say now is not in the slide. So I'm going to tell you that from the deep of my heart and of my mind. So this guy was called Fyodor Servinenko. He was a Soviet neurosurgeon, and of course at the time, I'm talking about 1964. It was the middle of the Cold War, and of course many techniques that were available in Western Europe and the US were not available in the Soviet Union. So he was having a Sunday family day in the Red Square in Moscow, and he suddenly saw little children playing with balloons. Balloons were floating because, well, you know, balloons are filled with helium or with hydrogen. I don't know what they are filled with, but they're floating. So he was a neurosurgeon, and he had noticed that many difficult to treat lesions were inaccessible for a complete treatment by surgical means. So he first had the idea of occluding balloons, of occluding the lesions with balloons. So I'm sorry, I'm having a phone call. So he first had the idea of fabricating a latex balloon and driving it into the bloodstream with a catheter, and then occluding carotid cavernous fistulae, which are lesions we are not going to talk about today, but these were the first lesions what were treated by these means. So to simplify, you have a huge vein in the brain, which is deeply located, which is the cavernous sinus, and the carotid artery forms a siphon within the carotid sinus. So it's kind of strange to have an artery inside a vein. But in fact, as the carotid has two fixed points, one at the entry into the skull, and the second one at the exit from the carotid, from the cavernous sinus, and enter the intracranial cavity. When you have a huge cranial trauma, you have shear stress that will tear apart the carotid artery and make a hole within the carotid artery. But as it is located within a huge vein, it makes a fistula. So patients usually have a swelling of the orbit. They have tinnitus with pulsatile rhythm, and it's surgically very hard to treat because you have to open the cavernous sinus, which is the vein, and you will have a lot of blood pouring out from your opening, and you have to deep dive into the carotid sinus and try to occlude the hole in the carotid artery. That meant at that time the sacrifice of the carotid artery. So he had the idea of coming into this hole, navigating inside the carotid artery, and then driving balloons into this cistern, this venous cistern, which is the cavernous sinus, until it's completely filled. Once it's filled, blood cannot come into, and the patient is healed, and you preserve the carotid artery. In fact, it's a very smart mechanism that he made himself the balloons with kind of handicraft, because it was not series fabrication at the time, but he was the first pioneer, of course, before any American did it or any other European. So he's the father of what at the time they called interventional neurosurgery or interventional neuroradiology. So our professor, both for Dr. Madden and myself, is Dr. Centeno. I will show. Yes, the answer is yes, Fran. Yes. So I told you that what I'm explaining now, I don't have that in the slides. So, he trained, as I'm going to explain in the next slides, at the mid of the 90s, which means about 30 years later. Because, of course, once they started to do this technique in the Soviet Union, very quickly, Americans and Europeans started to improve the techniques. So by the mid-90s, another neurosurgeon, an Italian neurosurgeon, invented coils, which are the milestone for the treatment of intracranial aneurysm. I'm going to show that right now. So our professor trained in the University of California, Los Angeles, the UCLA, which was the world pioneer in this technique, because before that, there was not an easy solution for aneurysms which were not huge and devastating as the one I told you before. So with this new technique, I'm going to show you more reduced or more kind of easy to treat aneurysms were dealt with this technique. So what is the interventional neuroradiology? We call that both in Los Angeles and Mexico, interventional endovascular therapy. So we started, as I told you, our professor graduated from in 1986 in radiology and neuroradiology. And then he went to the UCLA, and he signed an agreement with the Instituto Nacional de Neurología and the UCLA to start a joint venture in introducing these new techniques in Mexico. So in 1988, he founded the first neurointerventional and neuroradiological department in Mexico City, because until now, most neuroradiologists were trained abroad. There was no school in Mexico, because, originally in other countries, neurosurgeons and neurologists had additional training in radiology, which is kind of strange, because in other specialties, this was performed originally by radiologists. But in neuroradiology, there is a huge cooperation in between clinicians and radiologists. So he founded the chair of neuroradiology so that Mexicans could be trained locally. So these are, great leaders. Vinuela is from California. Dion is from Montreal. Merlin is from Paris. Casasco, even if he's an Argentinian guy, he immigrated to France. And of course, Professor Theron is also from France. So our professor rotated during these years, kind of 2 or 3 months with each one of them. And in 1981, he founded the SILAN, which is Sociedad Ibero-Latinoamericana de Neuroradiología, which is the first association of neuroradiology encompassing all countries. And it was founded in Mexico City. It was, it was founded in Acapulco, but I mean in Mexico. And in 1990, the first patient was treated worldwide in the UCLA with coils. Coil is an English word which means something that is like a loop, a metal loop, for example, to conduct electricity. And in fact, based on this idea, this other very smart Italian neurosurgeon, whose name was Guglielmi, invented this coil to be deployed into the aneurysm. Before that, we only had balloons and other like coarse materials that try to induce thrombosis, but this thrombosis was not totally controlled. So many times the candidates were all the aneurysms where you would sacrifice the artery, because if the thrombosis surpass its original goals, your artery should totally become occluded. If you did not have enough collateral circulation, of course, you would have a stroke. So there were very few candidates for endovascular treatment. But Guglielmi designed very tiny materials which are made of platinum. Most coils until now are made of platinum, which is expensive, but is flexible metal that keeps memory. In fact, when coils are fabricated, they have loops, round loops, and then they're put into a sheath. A sheath is a kind of like a pipe which is empty, and you put the coil which is straight. And once it comes out from the sheath, it recovers its memory, and as it's loop shaped, and most aneurysms are round, you occlude selectively the aneurysm without touching the vessel. So for the first time in history, you could occlude selectively the lesion without occluding the parent vessel. A parent vessel is a vessel that harbors the lesion. So in fact, at the beginning of the year, the first patients were treated in UCLA in Los Angeles, and both our professor and another teacher from Buenos Aires, whose name was Pedro Lilic, both traveled to be trained at the UCLA, and a few months later, the first patients treated outside the US were treated in Latin America by these two guys who were the students of Professor Vinuela. So in 1991, the Sociedad Mexicana de Neuroradiología, the Mexican Society of Neuroradiology, was founded. So as you can see, in a very short span of time, many societies that would set the foundations for these specialties were founded in Mexico. So in 1992, for the first time, our professor made the proposal for the National University in Mexico to set a new specialty. But at the time, university leaders thought it was just a technique. So they said, why should we found a new specialty if this is only a technique? And that's, I think that's the merit of our teacher, to have created worldwide a new specialty that sets completely apart from neuroradiology, from neurology, and from neurosurgery. So then 2 years later, he proposes again, and it's rejected. So at that time, at the National Institute of Neurology in Mexico City, they create two positions for diagnostic neuroradiology. So then in 1995, for the first time, interventional neuroradiologists were trained in Mexico. So the first one was a neurosurgeon from Panama, and the second one was a neurologist from Colombia. So, but they were trained at the National Institute of Neurology, but without any college degree. So in 1996, there comes the first Mexican resident. I'm not in the slides, but I first came with Professor Centeno in 1997. And in 1998, the third proposal was accepted by the National University of Mexico. And for the first time, as they thought it was a neuroradiological specialty, they accepted only neuroradiologists. As an exception, they accepted neurosurgeons or neurologists. And in 1991, officially, the first resident with a college degree comes into the Instituto Nacional de Neurología y Neurocirugía. And in the year 2000, for the first time in the US, they opened a residency in interventional neuroradiology. So for us, it's very important to emphasize that we started this specialty 2 years before they formally started it in the US. So in the year 2002, they split the departments in one is therapeutic neuroradiology and the other is diagnostic neuroradiology. And in the year 2004, finally, the university accepts specialists coming from all the three fields of the neurosciences. So, and 3 years later, Americans start to accept neurologists, and 1 year later, France accepts neurologists, because until then, they only accepted neuroradiologists. So, until the time I prepared these slides, which is not very recent, I'm sorry, we had graduated 70 physicians in our country. 45 of them were Mexicans, and of course the rest were foreigners, coming mainly from Central and South America. 60% of them are neurosurgeons, 30% are neurologists, and 10% of them are neuroradiologists. So what is very important to understand about this specialty is that it's not neurosurgery, it's not neuroradiology, it's not neurology, it's a new discipline. So, I'm going to go into the core of the subject. So this is the history of devices. I already told you that in 1991, the first code was introduced. And in 1997, Higashida in San Francisco performed the first stent-assisted coiling. And the next year, we performed the first soul stenting technique, which is a technique that was invented in Mexico. And we only place a stent across the neck of the aneurysm, and by kind of creating a diversion of flow, we facilitate the aneurysm to occlude itself by stasis. So, well, this is long. So these are our publications. This is the first case series where we devised this technique, and we call that the soul stenting bypass, because as you might know, bypass is a surgery when you make an anastomosis in between another vessel and another one. But this is an endovascular bypass because you put a bridge across the neck of the aneurysm. So we treated 3 vertebral aneurysms, and it was published in neurosurgery. Then in the very next few years, in the year 2006, we published this series where we started to use for the first time in the world what we call balloon expandable stents. Stents can be either self-deployed. A self-deploying stent opens spontaneously and reaches its maximum diameter, and you don't need to apply any force into the stent because it's a self-deploying stent. On the other side, balloon expandable stents, you need a balloon to expand the stent. But until this date, it was virtually impossible to navigate into the intracranial vessels because, as you know, intracranial vessels are very tortuous, and the technique did not allow to fabricate balloons which were soft enough to navigate into the intracranial vessels. So these balloon expandable stents were invented by Zenteno, which is the first author, and by Dr. Freitas, which is who is an interventional radiologist from the University of Sao Paulo. So they gave some directions and instructions to engineers on how they needed the balloon to be fabricated. So this is a case series of 70 patients. Half of them are from Mexico, half of them are from Brazil. And this allowed to get approval both from the FDA in the US and have the CE mark from the European Commission. Aneurysms located at the superior cerebral artery. It's also published in the Journal of Neurosurgery. This is another case series in Neurosurgical Review. This is our our Academy winning article because it has been quoted far more than 100 times because for the first time we did a prospective series of patients which were intentionally treated with the soul stenting techniques, aneurysms of the posterior circulation that were difficult and inaccessible to classical surgical techniques. So this is the first, no, this one, I'm sorry. After having treated, I'm sorry. This is a 10-year follow-up of the first treated case. So I'm going to show you the cases now. So these are different techniques of dealing with intracranial aneurysm. You can do a parent vessel occlusion, as I already told you at the beginning of the lecture. You can trap the lesion with clips. You can make perform a bypass and occlude the artery. You can put a clip. You can put a coil. You can deploy a stent. You can use balloons. And now you can use a flow diverter. So as you can see, you have so many available techniques, because in spite of being like a lesion with the same pathophysiology, make that this problem cannot be easily solved by one single technique. So there is not a single solution, because it's not a simple solution. So stenting in aneurysm is not a tool, is not a technique, but is a different approach, a different philosophy of dealing with these techniques. We published these 2 papers in a Mexican journal in Spanish, to be available to physicians and to patients. And we explain in these 2 papers the basic concepts and the basic devices that are available to treat these lesions. So we also devised this term that was coined by us, which is called the aneurysmal complex, because you have a sac that we are going to draw, but in fact you have a diseased parent vessel. So in fact, here you have the sac, but here you have the vessel, and this vessel is not straight. This vessel has many irregularities surrounding the aneurysm, which means that it is not a focal disease, but like a disease of the whole segment. So you cannot treat only the sac, you have to treat the parent vessel. So these are different forms, different geometric forms of aneurysm. You can have a fusiform aneurysm, and you don't properly have a sac. You have only a diseased parent vessel. Here you have a saccular aneurysm, and here you have an aneurysmal sac, and one can think that you do not have a diseased parent vessel, but in fact you do. So should we only target the aneurysmal sac? But this saccular approach leaves this diseased parent vessel without any treatment. So what we propose at the time is that this mostly ignored segment should be treated also. So, I'm sorry, if the aneurysmal sac is the consequence of a diseased parent vessel, to treat the sac would be to treat the consequence without dealing with the cause. So in some cases, it might be enough, but long-term results are often unsuccessful. And in some other cases, you have recanalization. So the technique evolved since I started with only coiling. This is a drawing of coils in a saccular aneurysm. You also have balloon-assisted coiling, because you have a large neck. Coils, when they are deployed in the aneurysm, will protrude into the sac. So this is stent-assisted coiling, because you put a balloon-assisted coiling. Of course, the balloon totally includes the vessel. You cannot leave the balloon because you would have a stroke. Instead of that, you put a permanent device to support the coils, and this is stent-assisted coiling, which was used in the States before it was used in Mexico. But we invented, but all these three approaches, you treat the sac. So all these, in fact, are endovascular approaches. But in fact, the sole stenting technique that we designed is the only technique that will treat the aneurysmal complex. So, well, I already explained to you all these articles that support what we are saying. And in fact, you have laminar flow, and this laminar flow is disrupted by the geometry of the vessel where the aneurysm is located. But by placing a stent in the vessel, you will, in a certain way, establish again this laminar flow. So many years before we studied this, you have this in vitro research who showed that, in fact, you have a model which is made of glass, and you have injection of dye, of orange dye in this vessel, of blue dye in this vessel, and you see if you have nothing in the neck, all the dye will come into the sac and make some whorls inside the sac. But you place a stent, of course, the slipstream flow will be disturbed. And of course, there's slow penetration of blood into the sac on the long term will produce thrombosis, which is what my professor imagined that would happen. So look at this. And if you place a stent, this is simulation, and you don't have this inflow into the sac, you have a small inflow just into the neck of the aneurysm. So these are different shapes where you can see that the blood does not have the same angle of attack into the sac, depending on the variation of the angle that the main axis of the aneurysm has with the main slipstream flow in the middle of the vessel. So I'm going to show you some cases. So this aneurysm in the superior cerebellar artery is in convexity, and we use a balloon expandable stent, and we modified the angle of the vessel. This case was published in the Journal of Neurosurgery. So we can see here we have both vertebral arteries that come into one single basilar artery, and the basilar artery bifurcates into both cerebral arteries. And you have here two superior cerebral arteries. I remind you that posterior cerebral artery is supratentorial, but superior cerebral artery is infratentorial. You have the tentorium here. And as you can see, the curves of this artery are harmonious. But instead of that, you have the rupture of the normal curve. And as you have this rupture, this aneurysm was formed. And well, this aneurysm is not easily accessible by surgical techniques because, well, of course, this is a bidimensional angiogram. But if you imagine that in front of these vessels, you have the clivus, you have the skull base, and you have space that should be around 2 or 3 millimeters. And behind these vessels, you have here the brainstem, and you also have a lot of space. So in fact, to approach this aneurysm, you should come from this angle, but it's very deep located. This is this midline. But on the other side, the endovascular approach is extremely easy. You puncture the groin, which means the femoral artery, or the wrist, which means the radial artery, and in 2 minutes, you are here. Because once you have in the bloodstream, your guide wire comes very easily here. You can catheterize the artery, and then here we place a stent. The stent is not visible because of the dye of blood, but you can easily see how the stent, which is made of metal, corrects the artery, and it becomes totally straight. And this is the normal angle before the stent was placed, and then this is the new angle. And this aneurysm was treated by only placing stent at the neck. Here you can see the modifications, the angle modifications, and then this is pre-stenting, this is post-stenting, and on the follow-up, you don't see any more the aneurysm. But which is very interesting is that by having placed the stent, not only the aneurysm was occluded, but this artery appears, and this artery previously, due to still phenomenon, did not opacify correctly. But in fact, it might be this artery that at the time we placed the stent, we did not pay attention to it, but after having corrected the vessel, this artery appears again. And this is the follow-up at 2 years. You have small residual of the aneurysm, and this is the stent within the vessel. So this was published in the Journal of Neurosurgery. So you have convexity, concavity, and this is endovascular approach with only coils. This is a clip placement. And this is a balloon-assisted coiling, and this is a stent-assisted coiling. And this is the sole stenting technique. So you modify the vessel by placing a stent, which is permanent. We have a second case where we have an aneurysm at the ophthalmic segment. The stent is in the convexity, and we use a self-expandable stent, and later we place coils. We do not modify the angle because a self-expandable stent, which is smoother, is not as hard as a balloon expandable stent. So this is not our figure, is well drawn from a paper, which is not our paper. So you can see here the stent, which is placed across the neck. This is the carotid artery. This is the ophthalmic artery. Here you have a huge ophthalmic artery aneurysm. This is the microcatheter. Through the microcatheter, you deploy coils. And this is our real case, which is very similar to this drawing. And here we have like a reconstruction where we can see the parent vessel in white, and we see the saccular aneurysm in red. And this really modifies the angle. Here we have another case of hypophyseal segment. These aneurysms are uncommon because they are located in concavity. We treated that with the balloon expandable stent, and we modified the angle, and then we placed coils. this, as you can see, well, this is the carotid artery. This is a lateral view. You have here the ophthalmic artery. You have the branches of the middle cerebral artery. You have the branches of the anterior cerebral artery. And here you have a saccular aneurysm that we can treat here. We place a balloon. This is a balloon which is placed on a microcatheter, and then you deploy the balloon across the neck. You place coils supported by the balloon, and at the end you place a stent. So you can see the metal is in white. You have the balloon and you have the coils, and now you have controlled the aneurysm. Well, and of course, well, I have lots of other cases. I think that now I'm in slide number number 58, and I have 157 slides. So I think that by illustrating our technique with these three cases, we can now go to discussion. You have some questions. I have many other cases I can show you because, well, we have been doing this for more than 25 years now. So I will just show you this case, which is where like a first star case. This was published in the year 2010 for the 10-year follow-up of this giant basilar aneurysm treated by the soul stenting technique. So this was a lateral basilar aneurysm, which was saccular. We used a balloon expandable stent, and we modified the angle. So this was the first page of the paper. So look how huge is this aneurysm. Here you have the roof of the orbits. You can imagine that this aneurysm is as large as the eyeball. Well, this CT does not cut the eyeballs, but it's about the same size. So we have the right middle cerebral artery, the left middle cerebral artery, and this huge aneurysm will make a compression on the brainstem. Here you have the magnetic resonance imaging. Here we have the digital subtraction angiography. Here you can see that the vessel comes here, and then it turns around and goes the other way around. And we rotate slightly the view, and you can see that this huge saccular aneurysm is on the side of the parent vessel. And here you have the dye, which is penetrating within the sac. And we place a stent across the sac, and you can see that the aneurysm was totally occluded without the need of placing coils. So this is the 10-year follow-up angiogram, and you see that the stent is well tolerated. The patient has been alive without any further bleeding for 20 years now, because this article was published 13 years ago. So, well, that's everything. That's all for the slides. Well, do you have any questions or remarks?
Thank you, Dr. Lee. It was excellent, your talk. And I don't know if anyone has any questions, so we can start with them.
Don't be afraid to ask. There are no silly questions, because, well, I think that is something totally new for you. So, well, in the chat, I put my phone number in. If after or later on somebody wants to have additional explanations or needs the papers, I can send them to you by WhatsApp or by email.
I
So,
think someone has
Alejandro,
a question. Alejandro
yes.
has a question.
Yeah, thank you very much. Well, my question is about if in a case where the stent is used, but the aneurysm doesn't develop as well and won't be any further good evolution, what will be the next approach in that situation?
Well, I think that when you say evolution, you mean that it does not occlude. Is that
Yeah,
right?
right.
Okay.
Yeah.
Well, it depends on the presentation, original presentation. You have schematically, you have ruptured aneurysm and unruptured aneurysms. With ruptured aneurysms, we hesitate to use only the sole stenting technique because, of course, if the aneurysm is not occluded, you will get in trouble. So with ruptured aneurysms, usually we place coils, then we place the stent. And even you have some recanalization, if the recanalization during the follow-up imaging studies does not increase, in fact, this partial occlusion of the aneurysm prevents from rebleeding, which is the goal of treatment. You have unruptured aneurysms that are treated like preventive medicine because, of course, you have an intracranial aneurysm with a very low procedural risk of complication of rupture. And on the other side, you have the risk of rupture. And if the aneurysm ruptures, you will have a subarachnoid hemorrhage with this small prognosis. Most patients choose to be treated in a preventive fashion. And in this case, we can take the risk of having a partial occlusion and making a follow-up imaging for the patients. So in that case, it depends on the imaging evolution. If the aneurysm doesn't occlude at all and there is no modification, you can discuss with the patient either to try to place coils across the mesh of the stent because the stent is not totally closed, it's a mesh. So you have holes and you can navigate the catheter into the sac and place coils, or have open surgical technique to put a clip across the neck. So I hope my answer was clear.
Yeah, it was really, really great. Thank you very much.
I don't know if someone else has also a question. Someone?
All right, I have a question then. So my question here is, how do you choose a flow diverter from placing a conventional stent when you're managing an aneurysm? Is it because of the taxonomy of the aneurysm? Do you rely on the location of the vessel or how turbulent is the flow, for example, here in the basilar? So yeah, how does your criteria work when making these decisions?
Well, it's a very tough question that cannot be easily answered, but it depends. Unfortunately, in Mexico, it depends on how much money you have, because even stents are quite expensive. Stents, well, cost around like $4,000 to $5,000, which means around 100,000 pesos. But flow diverters are 3 times as expensive, which means 300,000 pesos, which is a huge amount of money, even for me. If I had myself an intracranial aneurysm, I don't have 300,000 pesos in my bank account to pay for the device. But this is the price only for the device, but you have microcatheters, you have the hospital fees, the medical fees for the doctors. It's very expensive. So if you have an insurance and you have the choice and there are no money problems, it depends on how confident you are on the technique. In fact, myself, I'm a professor, we are relatively conservative and we trust a lot this technique, which is cheaper. But many younger doctors like fancy treatments and they place expensive flow diverters across the neck of the aneurysm. And because these flow diverters have different structure, they have a mesh which is which holes are smaller. You have more metal. They occlude more easily. Though if you want to go for sure, you should place a flow diverter stent. You can have and see how it becomes along with time. You would use a sole stenting technique. But you don't have money or your money is limited, you don't have the choice, in fact. I don't know if it answers your question.
It does. Thank you. And last one for me is, well, I mean, we know that endovascular techniques are now a lot sexier or a lot more convenient than open cerebrovascular approaches because it's less invasive. It's probably less expensive for the patient. But now that you say the cost of these devices, we don't know. But what would you say are certain limitations of endovascular techniques nowadays, like when you compare this to open cerebrovascular approaches?
Well, your question is very difficult too, because there have been several books, I think more than a dozen of books that compares both techniques. Well, I have a philosophical principle to answer that technique. And I call that in Spanish local geography. You have an endovascular surgeon who is very skillful, and you have an open neurosurgeon who has a poor technique, the choice is evident. But on the other side, if you go elsewhere under local geography, you have an ill-trained endovascular surgeon, and you have excellent hands of an open neurosurgeon, you have no choice. The problem is that often patients do not know that. And if you are honest with yourself, you should either receive additional training or perform laboratory training or whatsoever. That's your personal problem. But you have equal level in your hospital. It's hard to answer because, for instance, in Mexico, because of costs, I don't know if we have statistics in our country now of how many aneurysms are treated by one technique or another across the whole country. But I think that less than 25% of aneurysms are treated by embolization techniques. In the US, I think that it's around 60% endovascular, 40% surgical. But in Europe, especially, for example, in Scandinavian countries, in Germany, above 90% of aneurysms are treated by endovascular techniques. So the problem is that people who are my age, who are open neurosurgeons, they're well trained because they had a lot of cases. But open neurosurgeons who are trained now do not have a lot of cases. So I think that in Mexico, we will see in the next few years the same evolution than in other parts of the world, especially if there is support from insurances or government. to subsidize these techniques. And the other problem we have discussed very long time ago, more than 20 years ago, I discussed with a guy from the company that came from the US. And I told him, but in Mexico, devices are 4 times more expensive than in Germany. But in Germany, people have wages that are 20 to 30 times higher than in Mexico. So in fact, devices here are 100 times more expensive. Why don't you lower the prices? And they say it's just a question on offer and supply. So I don't know why they don't lower the prices, because they are extremely expensive for our economy. But I think that this might change in the next coming years.
All right, thank you very much. Any further questions for Dr. Lee?
Yes, because it's almost an hour we have started. That's why I stopped my slides, because I could have talked another additional hour. So
Yeah, I know. So if there's no further questions, I thank you very much, Dr. Lee, for this excellent presentation. It has been an honor to listen to you, and we hope to see you soon. Thank you.
Well, thank you very much.
Thank you, everyone.
See you next time. See you next year.
Thank you. See you next year.
Yeah.
Thank you.
Thank you very much.
All right, thank you for joining us.
Thanks.
Thank you, everyone.
Bye.
Bye.
Bye.